The first things first, regarding the urinary tract system, I think you are already acquainted with the normal anatomy. It will comprise of the kidneys, the ureters, the bladder, the urethra, and the external genitalia. Overall, the most common infections worldwide in all settings are the urinary tract infections. Now, urinary infections can be divided into two types. The first type is called as the ascending type of infections, and the second type would be depending on the location where the infection is occurring. Either it is hospital or healthcare acquired, or it's a community acquired. More importantly, from the patient's point of view, we need to ascertain whether the urinary tract infection is a lower urinary tract or an upper urinary tract infection. The anatomical delineation is the idea. What is the anatomical delineation of differentiating between the urinary upper and the lower urinary tract infections? So, any infections involving the bladder and the urethra will be considered as the lower urinary tract infections, and any infections which involves the kidneys or the ureters will be considered as upper urinary tract infections. If you look at the differences between the two types of infections, very important is that when you look at the route of the spread, in case of upper urinary tract infections, the spread can be from both ascending or descending. Whereas in case of lower urinary tract infections, the route of spread is through the ascending. Furthermore, in the upper urinary tract infections, the organs involved will be the renal, the kidneys and the ureters. Hence, systemic manifestation will be more profound. However, always keep in mind, this is a total process. So, an infection which may start off as a lower urinary tract infection, but may eventually spread upwards to become upper urinary tract infections, right? Okay. Now, if we look at the causative agents causing urinary tract infections, I think you already know the most important cause of the bacterial causes. Similarly, we can differentiate the bacteria whether depending on the gram reaction, whether gram positive or gram negative. And among all the bacteria, I think you already are acquainted that Enterobacteriaceae are the most common cause of urinary tract infections. However, you should also be aware of other causes which can cause urinary tract infections. Most importantly is the fungus, commonly the yeast or the candida species, and certain viruses like BK virus and some parasites like Schistosoma. Now, in today's case discussion, I will go on and discuss various types of cases with you, and I hope you will participate in that. Now, let us look at the first case. What is the first case? A 23-year-old sexually active woman presents with dysuria, urgency, suprapubic pain for 2 days. However, there is no history of fever or any kind of genital discharge. So, what would be the provisional diagnosis based on this history? Yeah, it would be urinary tract infection. More precisely, we can say because there is no fever or systemic involvement, probably this is a lower urinary tract infection. So, our provisional diagnosis would be acute. Why acute? Because the presentation is for only 2 to 3 days. So, it's acute. And why we are saying it's uncomplicated? Because lower urinary tract infections are uncomplicated. Now, here is a very important point that you should remember. When we say complicated urinary tract infections, that means there is a process which is going on which hinders the normal flow of urine. Now, this process could be an anatomical abnormality, maybe a congenital defect, maybe a foreign body, maybe a stent, or any kind of urogenital procedure, instrumentation, surgeries that may hinder the normal flow of the urinary tract. All these are considered as complicated UTI. Understood? A very important aspect is urinary tract infections in males. Keep in mind, UTI in males is always complicated. So, when we say acute uncomplicated UTI, this would be the typical presentation. Now, what would be the common organisms causing uncomplicated UTI? Most common organisms will be the organisms that are present in the gut of the patient, that is through the enteric bacilli. What would be the investigation that we would consider? First is, most important is, you have to examine the urine for routine examination and microscopic examination to understand whether there is actually signs of inflammation or not. That can be ascertained by presence of pus or presence of leukocytes. Next, culture may be required. Generally, uncomplicated UTI is very common in females. Culture is not required routinely. Empirical antibiotic therapy is sufficient. However, repeated infections or recurrent infections, that is at least 4 episodes in 1 year, if it is occurring, then we need to go for culture. So, empirical treatment means the treatment we are giving to the patient without going for the culture or looking for a specific susceptibility. The empirical treatment would be using either nitrofurantoin or fosfomycin. Okay. Coming to the next case, a 65-year-old woman, diabetic, has bacteriuria. Okay. Because of other causes, a urine culture was done and the urine culture has reported significant bacteria. What is significant bacteria? That is more than 10 to the 5 colony forming units per ml. Now, what to do in this case? The patient is asymptomatic. So, will we treat the patient or not? That is the important question. So, this diagnosis would be asymptomatic bacteria. That means the bacteria is present in the bladder, however, the patient has no symptoms. Generally, treatment is not required. However, if this patient has some specific indications, like if the patient is pregnant, that means she will undergo some kind of a procedure or any kind of urological surgery or procedure. If we do anticipate these procedures are going to happen, we need to treat. Why? If without giving the antibiotic we go through the process, we will be actually allowing the bacteria to enter into the tract and cause upper UTI. To prevent the upper UTI, we need to give the antibiotics. Let us look at another case. A 70-year-old male admitted, was catheterized. After 2 days, develops fever and altered mentation. So, what would be this diagnosis? Right. This is what we call is as catheter-associated urinary tract infections. However, keep in mind, the catheter must be in situ, that is placed within the patient for at least 48 hours or 2 calendar days. Obviously, the risk factor would be poor immune system, long-term infections, diabetes, poor infection control, and a very important part for diagnosis in case of catheter-associated UTI is urine culture should be done where the urine should be collected properly from the sample port, not from the urobag or otherwise. Let us look at another case. A 32-year-old female presents with fever, chills, flank pain, nausea and dysuria. Now look carefully over here, the patient has symptoms of urinary tract infections. Along with that, she has systemic signs like fever, fever with chills and flank pain. So this would indicate the patient probably has upper urinary tract infection. When it involves the kidney, we call it as pyelonephritis. Why? Because most of the time we cannot delineate whether the infection is restricted within the pelvis of the kidney or the nephrons itself. That's why we call it as pyelonephritis. Now keep in mind, pyelonephritis infection can be acquired either when the organisms ascend from the urinary tract or may descend. When we call it descending, that means the organism is entering in the kidney from systemic circulation or blood circulation. So, very important part over here is to evaluate the patient for systemic signs and look for costovertebral angle tenderness. If that is present, that means there is inflammation in the renal region. Now over here, along with the other diagnosis of UTI, including urine examination and culture, we also need to do more investigations. What are the other investigations over here? Very important would be to get an ultrasonography of the kidneys to look for signs whether it's inflamed or not. We need to also take the blood cell counts, and if indicated, even blood cultures may have to be done. Many a times, abscess may be seen in the renal area. That can be detected by imaging studies like USG or CT or MRI. These are the common infections of the urinary tract. However, other infections like renal tuberculosis can also be seen. Now, in that case, it would be classified as extrapulmonary tuberculosis. And tuberculosis can affect the kidneys in isolation, or the ureter, or the bladder even. Okay. Another phenomenon that can occur is called as post-streptococcal glomerulonephritis. It is basically an immunological reaction after streptococcal infections, either from a sore throat or a skin infection. Furthermore, perinephric or renal abscesses may be there in isolation or as a part of other systemic infections. So these are the most commonly of the bacterial causes. Among the viral causes, a very important cause of viral infection is BK virus. Now this name BK comes from the patient who was affected. Okay. Now this infection is more commonly seen in people who are have undergone transplantation, either stem cell transplantation or solid organ transplantation. So post-transplantation BK virus infection is very common, and it leads to what is called as BK virus induced nephropathy. Like other viruses, the diagnosis is most commonly done with the molecular methods. Cultures can also be done, but those are not preferred. Although this is not very important for in your context, but please remember, post-transplantation BK virus nephropathy is very common. Moving on to the parasitic infections. Among the parasites, a very important cause of parasitic infection is called as Schistosoma hematobium. Other schistosoma are acquired and they live in the mesenteric vessels, that is, vessels of the gut. However, Schistosoma hematobium, they live in the vesicular venous plexus. When they mature, the female worm would penetrate the bladder wall and lay the eggs within the urinary bladder. The eggs will be released during urination and the cycle of the parasite will complete. Now keep in mind, every time the worm penetrates the bladder to lay eggs, it causes inflammation in the bladder. Chronic infection may lead to malignancy of the urinary bladder. I think there is always been a class taken on organisms causing malignancies or oncogenic organisms. So this is one of the organisms which may predispose to squamous cell carcinoma of the bladder. Okay. Diagnosis is mainly by detection of the antigen and antibody, and sometimes microscopic examination of the urine may reveal the eggs of schistosoma. Last but not the least, fungal infections of the urinary tract are also common. And normally we don't associate fungal infections in normal people. However, look at the subset of the people over here. People who are undergoing immune suppression, either iatrogenically or because of a disease. People who have been admitted in the hospital for a prolonged period of time and has been administered with broad spectrum antimicrobial agents. Furthermore, people who are critically ill and extremes of age group. That means at the early stage of the life or at a very late stage of life. All these people can be affected by fungus causing urinary tract infection. Why this is important? Because the infection, like the bacterial infection, will start as a lower urinary tract infection, then ascend and causing systemic infections. So that was all about the common urinary tract infections. Now moving on, we'll also cover the genital infections. I think a class has already been taken on sexually transmitted infections, and I think you are aware with the syndromic approach. So in today's class, we'll take the case-wise basis and look how we can proceed. So let us look at this first case. A 24-year-old male with a painless ulcer on the penis and non-tender inguinal lymphadenopathy. And this person has a promiscuous sexual history. On examination, you can see there is an ulcer on the shaft of the penis. Now, what would be this provisional diagnosis? No, your provisional diagnosis would be this is genital ulcer disease, because you have not done any investigation. So, under genital ulcer disease, although the history is suggestive of syphilis or primary chancre, but other differential diagnosis would include other causes of genital ulcer disease, which would include chancroid, herpes, LGV or donovanosis. Okay. Now for investigations, what investigation do we need to do for each and specific every disease, right? However, if we don't have the setup to get the person tested, we can go with the syndromic approach. So in syndromic approach, this would be characterized as genital ulcer disease in the non-herpetic category. I'll show you the picture of an herpes infection, and then you can easily understand why I am saying it is a non-herpetic. So now look at what the syndromic approach tells us. So this is a non-herpetic genital ulcer, and it's a single or a multiple ulcer. And what would be the drugs that should be given? It's benzathine, penicillin and azithromycin. Okay. Now let us look at another case. A 50-year-old man present with rashes on both palms and ulcer and even on the tongue. He had a history of painless ulcer on the penis about 10 months ago. He did not seek the treatment. The lesion resolved on itself. Now he is presenting with these signs and symptoms. So what would be this case? Bolo? Right. So we have a history of a ulcer that resolved on itself, and then the patient presented with these features. So what is these features? Ulcers on palm and foot with mucocutaneous ulceration. The diagnosis would be secondary syphilis. Now over here, now let us go through the diagnosis of syphilis, how we can diagnose. We can go for microscopy on active lesions to look for treponema, either sulfur staining or by direct immunofluorescence staining. I think you can see these pictures. As treponema is not cultivable, the main facet of diagnosis lies with the serological testing. Now, serological testing can be of two types, either treponemal test or non-treponemal test. What are non-treponemal tests? Non-treponemal tests are when we try to detect antibodies against the non-specific cardiolipin antibodies, whereas treponemal test we detect the antibodies directly directed against the treponema. Now, advantage of the non-treponemal test is that when the patient is being treated with antibiotic therapy, what will happen? The damage to the local tissues will go down. Hence, these non-specific antibodies titer will also go down. We can monitor the patient, the management of the therapy. However, the treponemal test once comes positive, it will remain positive throughout the lifetime. Okay. So the common non-treponemal test would include VDRL test, RPR test, TRUST or toluidine red untreated serum test, or USR untreated serum reagent test. Most commonly VDRL and RPR is done. Among the treponemal tests we have TPHA, TPI and TPPA. For diagnosis of syphilis we have two types of algorithm In the first algorithm, we go for testing for the non-treponemal test. If that comes positive, then we test for the specific treponemal test. There is another algorithm called as the reverse algorithm test, where we can go for the specific treponemal test first and then go for the non-treponemal test. Whatever algorithm we may follow will totally depend on the availability of the testing facilities. Okay, let us look at another case. A 24-year-old male with a painful ulcer on penis and tender inguinal lymphadenopathy. He has a history of a unprotected sexual exposure 5 days ago. That means the progression is very rapid. Furthermore, not only the penile ulcer is painful, but also the inguinal lymphadenopathy is also painful. So, what could be the provisional diagnosis? So, this again, genital ulcer disease, most probably this is chancroid caused by Haemophilus decrease. Okay. For diagnosis, the best option would be take the specimen from the ulcer bed, look for the gram stain, where we can see what is typically described in the textbook is school of fish appearance. It is a gram-negative coccobacilli appearing in a school of fish appearance. Culture can also be done, and even molecular testing can be used for diagnosis. Again, as far as the syndromic approach, this would be non-herpetic genital ulcer. The treatment would be same, using penicillin and azithromycin. Okay. Now look at this case. A 32-year-old male with a painful ulcer on the penis and again tender inguinal lymphadenopathy. The sexual exposure history is of 3 days. Now look at this picture. On the glans of the penis, you can see very small, almost fluid-filled ulcer. Small vesicles. So this is a typical presentation of herpes. Now I think you can differentiate between the herpetic ulcer and the non-herpetic ulcer. Now, if this is the typical presentation, how can we diagnose? We can, although painful, we can scrape the vesicle bed with a needle and do what is called as Zang smear. Or we can also use molecular methods to detect. Now, as far as syndromic approach, the treatment would be genital ulcer disease herpetic. And what would be the treatment? We need to give acyclovir. Okay? Fine. A 32-year-old sex worker reported appearance of a small, shiny, asymptomatic circular lesion on his penis and on the scrotum. After 1 month, the lesion excruciated and now presented with serous secretion. After 2 weeks, now I think the lower picture you can see of the inguinal region where there is an ulcer. That's an open ulcer with serous to purulent drain from the inguinal lymph node. So what would be the diagnosis? This is again genital ulcer disease. However, now we have involvement with the inguinal lymph nodes, right? So this is the typical presentation of lymphogranuloma venereal caused by chlamydia trachomatis. If you can remember the server, this is very well. So in the first stage, we'll find painless papule vesicle or ulcer. In the second stage, we'll have bubo, that is the swelling of the inguinal lymph node, fistula and systemic symptoms. Diagnosis is predominantly by the molecular methods because it is very difficult to cultivate them and antibody detection. Now over here, the treatment would be not only ulcer but also involvement of the lymph node. So we need to treat under the syndromic approach as inguinal bubo. That is, we need to give azithromycin and doxycycline for at least period of 2 weeks. Okay. Another case. 45-year-old male presented with painless ulcerative lesions over the genitals for the past 4 months. and there is frequent bleeding from the ulcer bed. Along with that, there is bilateral painless but firm inguinal lymphadenopathy. So this would also again come in the inguinal bubo category, but also a genetic ulcer disease. So this is called as donovanosis, caused by so for diagnosis we can take the specimen from the swab, either a swab or the ulcer bed, and if we do direct microscopy we can find the gram negative bacilli over here. These are also called as Donovan bodies. Culture can also be done. However, it is very difficult to culture in artificial. We need cell lines. Okay. Molecular methods have superseded for diagnosis. Now over here again the inguinal bubo, antibiotics will be azithromycin and doxycycline. A 22-year-old male presented with a purulent discharge and dysuria and after history of unprotected cells. On examination we can find pus at the tip of the urethra. What is this? No. The syndrome would be urethral discharge. Okay. So urethral discharge can be caused by Neisseria gonorrhoeae or chlamydia or mycoplasma. A probable indication is that in gonorrhea, the discharge is more purulent. In case of chlamydia or mycoplasma, discharge will be more serous. Okay, diagnosis is predominantly by microscopy and molecular methods because all these organisms are very difficult to culture. However, gonorrhea can be cultured, but it requires specific requirements like the swab that should be specific, and then we need to use thiamartin media and under certain conditions and chocolate agar with antibiotics. That is the thiamartin media. Okay. Other causes of urethritis would be, these are the most common causes, that is Neisseria, chlamydia and mycoplasma. Other causes of urethritis would include other bacilli like uroplasma. Even herpes can cause urethritis if it is infection is in the urethra, or fungal like candida and parasites like Trichomonas vaginalis. They can also cause urethritis. Treatment would be, as per as the syndromic approach, urethral discharge, we need to give azithromycin along with cefixime. Okay. Keep in mind, I am not going into the definitive treatment in each cases. As far as you are concerned, syndromic approach is sufficient. Okay. But you must remember the color coding of syndromic approach. Okay. Moving on. A 20-year-old male came with pain and swelling of both testes for 2 days. There is no history of trauma. However, there is history of unprotected sexual intercourse. So this is called as, what would be the provisional diagnosis? This would be, bolo, purano hoye jeto STI. উপরে কি লেখা হয়েছে? Painful scrotal swelling. So whenever a patient comes with a painful scrotal swelling, first rule out whether there is trauma or not. If there is trauma, that's a different case altogether. If there is no history of trauma and there is history of unprotected sexual intercourse or promiscuous sexual activity, your diagnosis would be painful scrotal swelling, most commonly caused by Neisseria and chlamydia trachomatis. So diagnosis would be almost similar to that as previously, but most importantly, you must be aware of the differential diagnosis. Not all cases of painful scrotal swelling would be STI induced. What are the differential diagnoses? Look over here. Tuberculosis, filariasis, infections with bacteria like Enterobacteriaceae, Pseudomonas, these are viral infections like mumps. They can all cause painful swelling in the testis and the scrotum. So you must evaluate to rule out these causes. Okay. Now, what would be the treatment? It is the syndrome would be painful scrotal swelling, and the pack would be the gray color, that is the kit 1. Azithromycin and cefixime. Okay. A 30-year-old woman has come to the OPD with a history of curdy white discharge and itching. So, what will be the provisional diagnosis? Vaginal discharge. What would be the common causes? Will be either Candida or Trichomonas vaginalis, or it could be bacterial vaginosis. Keep in mind, bacterial vaginosis is not an inflammation. It is the alteration of the microflora of the vagina leading to discharge. So, this is the table which differentiates between the 3 types, that is vulvovaginal candidiasis, that is caused by Candida, Trichomonas vaginitis caused by Trichomonas vaginalis, and bacterial vaginosis. Now, let us go through them. Obviously, candidiasis is most commonly caused by Candida albicans, may also be caused by non-albicans species. Trichomonas infection is caused by Trichomonas vaginalis, and at the last part, look, bacterial vaginosis, where it is not caused by Gardnerella vaginosis, but alteration of the flora. Symptoms would be discharge and itching in all 3. However, the discharge will be slightly different. In candidiasis, the discharge would be scanty, thick. In Trichomonas infection would be profuse white, and whereas in vaginosis, because it is just an alteration of the flora, it would be thin, moderate, and white to grey. Another important part is look at the pH of the vaginal fluid in bacterial vaginosis. Because the normal flora is altered, the bacteria which produces acidic environment, they are not there. Hence, the pH of the vaginal fluid will increase. Hence, the pH more than 4.5 is a big indication towards bacterial vaginosis. And on microscopy, we can find what is called as clue cells. So, what are these clue cells? Clue cells are nothing but epithelial cells which are filled with bacilli. Okay. So, as far as the syndromic approach, the treatment would be to use the green colored kit or the kit 2, which contains seclinidazole and fluconazole. What is seclinidazole? It's a antibiotic. Metronidazole naam sunecho? What is metronidazole? It is directed against which type of bacteria? Anaerobe. Okay. So, metronidazole, tinidazole, seclinidazole all act on anaerobic bacteria. Why seclinidazole is given? Simple, a single dose is sufficient. You can give metronidazole, but you need to give 3 times a day for at least 7 to 10 days. Now, this will help to get rid of bacterial vaginosis and also trichomonas. Along with that, we use fluconazole. Fluconazole is an antifungal drug. This is used for treatment of the candidiasis. Okay. Now, these are the cases where the pathology is in the vagina. However, if there is a pathology going on in the cervix, we can also have discharge. So, what are the infections that can happen in the cervix which lead to discharge? This would include Neisseria, that is gonorrhea or chlamydia, trichomonas, and even herpes simplex. Now, if there is inflammation of the cervix, there will be cervical discharge. It is very important that examination of the cervix, both inspection and bimanual examination is done, and prior to performing bimanual examination, swab sample from the cervix should also be taken for diagnosis. So, for cervical discharge, we need to give the patient kit number 1 or the grey colored kit, which comprises of azithromycin and cefixime. Clear? Because the same organisms are there. Neisseria, gonorrhea and chlamydia are the most common. Hence, we have to give azithromycin and cefixime. A 28-year-old woman came with lower abdominal pain, fever, and foul smelling discharge. Now, please look carefully. Lower abdominal pain and systemic symptoms, that is fever, along with that foul smelling discharge. So, what would be the provisional diagnosis? No, see, there is discharge, that means there is a pathology going on in the genital tract. Along with that, we have lower abdominal pain and fever. Those are systemic symptoms. That means there is an inflammatory process going on in the pelvis. So, we will classify it as pelvic inflammatory disease. So, what are the causative agents? It could be many organisms, gonorrhea, chlamydia, and anaerobes. Okay. Clinical diagnosis can be done by examination of the patient and pelvic examination. Now, PID can be primary or secondary. What is primary PID? Where obviously occurs either spontaneously without any history or after sexual exposure. Secondary PID can occur after any kind of instrumentation or intrauterine procedure, including IUD insertion. IUD is intrauterine contraceptive device insertion. Complications could include endometritis, that is inflammation of the endometrium of the uterus, salpingitis, euphoritis, and sometimes even extension into the peritoneum. Many patients will end up developing or complications in conception, that is, they can't get pregnant because of these reasons. Now, how to manage this case? For this, we need to give kit number 6 or the yellow kit, which will comprise of cefixime, metronidazole, and doxycycline. Cefixime and doxycycline for gonorrhea, chlamydia, and because in PID anaerobic bacteria also causes infection very frequently, we need to give metronidazole. However, keep in mind, we are giving these drugs for at least a period of 14 days. We need to evaluate the patient after giving the antibiotics on the 3rd day itself. If the patient does not become symptomatically better, we need to go for further diagnosis and change the course of the management. Now, coming to other genital tract infection in males, a very important infection is called as prostatitis. So, this prostatitis could be acute or could be chronic. Now, acute prostatitis is commonly caused by, again, Neisseria gonorrhea and chlamydia trachomatis, an extension of the STI. Now, this inflammation of prostate, the internal organ, will manifest. How it will manifest? With systemic signs: fever, myalgia, dysuria, pelvic pain. Okay, and treatment will be simple, giving ceftriaxone and doxycycline. Coming to chronic prostatitis, the disease process is more indolent. However, if we look at the etiology, most commonly caused by enterobacteriosis, that is the gut flora. And it will present with low-grade fever, urinary frequency, dysuria, perineal discomfort, and sometimes even bladder outlet obstruction. Features like bladder outlet obstruction, that is difficulty in urination. Now, for this, we need to do what is called as 4-glass test. Now, please look over here. I think you have understood about most of the common causes causing inflammation in the prostate. So, in the 4-glass test, what we do is we take 4 test tubes and we collect 4 types of sample. What are the 4 types of sample? First is called, we ask the patient to urinate and collect the early part of the urine. Then the midstream. Then we induce a procedure what is called as prostatic massage. Parectally, we palpate the prostate gland, and on palpation, on giving the prostatic massage, the prostatic secretion will come out. We collect that prostatic secretion in the 3rd tube, and finally, after the prostatic massage is given, we ask the patient to urinate again and collect that urine. Okay. So, why we are doing this? What is the significance of collecting early part of the urine? So, when we are collecting the early part of the urine, we are collecting the urine that is coming out through the urethra. So, that would be very important to diagnose urethritis or common cause of urethritis. The midstream urine, as you know, is very important to collect or detect cystitis. And for proper diagnosis of prostatitis, we need to go for detection of the prostatic massage secretion and the urine collected after the massage is given. Okay. So, this is called as 4-glass test. Another common infection that can be seen is called as epididymitis, acute inflammation of the epididymis, most commonly caused by chlamydia trachomatis and Neisseria. However, epididymis can also follow after systemic viral infections also, including orchidosis. Next is genital tuberculosis. Now, keep in mind, tuberculosis can affect any part or any organ of the body. Likewise, in the genital tract in females, tuberculosis can affect the ovaries, the fallopian tubes, the uterus, both endometrium, the myometrium, and in case of males, from epididymitis to even prostate. All these infections can be seen caused by tuberculosis. Coming to anorectal infections, these lesions can be seen generally in the perianal region and sometimes even the penile shaft. This would include, first part is called as molluscum contagious. Look at the picture over here. Small swelling, pus or granulated material, cheesy material is seen within this swelling, and if you can appreciate, the top of the swelling is depressed, also called as umbilicated swellings. This is caused by pox virus, molluscum pox virus, and the treatment is basically to get rid of the lesions because they will spread very rapidly, especially if the patient itches or uses the fingernails. The next would be what is also called as crab lice, that is body louse infection. So, the Pyelonephritis pubis commonly reside in the pubic hair and they can also spread during sexual intercourse. Similar to that, another ectoparasite infection may be seen, that is called as scabies, caused by Sarcoptes scabies. Permethrin can be used. So, these are the common infections of the genital tract. I think I have covered most of the infections based on the cases.